Fabulous. Welcome all. I'm Dr. Owen Muir, and that's not the, that's the last slide. That's the last slide. Well, now you know the punchline. I'm going to try to convince you that that is true. Thank you. There we go. So I'm Dr. Owen Muir. Here are some of my many roles and positions. I'm the medical director of Brooklyn Minds and have a number of other appointments as well. In tradition with all talks I have to give, I have my disclosure slide for all of my conflicts of interest, as you can see. Kind of pertinent to this talk, my work with the On Men Clinic as a consultant, and I received honorariums from them as well, and NAMH, as well as the OMH facilities funding has contributed to this talk. The most important disclosure is that I've been accused of being a maverick. And I think they meant it as an insult. I always took it as a compliment. I want to start with some facts about the brain so we're all on the same page. There are more neurons connecting to other neurons in your brain than there are stars in the sky. And when I say that, I'll clarify. Stars in the entire universe, in the entire known universe, more connections between the neurons in our brain than all of them. The consistency of the brain in the human head, in the living human, is that of soft brie cheese. It's very soft and viscous and jello, and it lives inside the skull, which is full of bony, hard, sharp ridges. And so when we have acceleration and deceleration of the head, this is why football is a terrible idea, you can have all the helmet you want. It actually just makes it worse. There are way fewer injuries in rugby, for example, than there are in football, especially American tackle football, because the damage is all inside your head, because this brie cheese thing gets moved back and forth, and you have shear stress injury on the axons, which can cause significant difficulties. So that brings us to some of my work as a psychiatrist. And I want to explain how we as psychiatrists make a diagnosis now. What's the state of the art officially? So these here are the symptoms of major depressive disorder, which should be one of the easiest things for a psychiatrist to figure out. These are all the criteria from the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders. So we have depressed mood, anhedonia, which is the inability to experience pleasure. It's the opposite of hedonism from the Greek. Sleep disturbance. It can be up or down. You can see how specific this is. Guilt or worthlessness. Poor energy, poor concentration. Appetite disturbance, up or down. Suicidal thoughts or even behaviors. And psychomotor retardation or agitation. So being physically slowed up or slow down or sped up. Now, to compare that, these are the symptoms of traumatic brain injury, or some of them. It obviously varies with the degree of severity. But anhedonia, there our friend is again. Depressed mood, again. Poor sleep. Trouble with memory or concentration. Confusion. And there can be things like lightheadedness and ringing in the ears, which are kind of easy to write off as somatizing in someone who's depressed. Oh, it's all in your head. Well, yeah, that's the kind of point. So how can we tell the difference in this field when what we do is we sit down and talk to people? Did you know that psychiatry is essentially the only medical specialty that never routinely looks at our organ of interest? Imagine this. You go to an orthopedist for your broken leg, and he just asks you questions about breaking your leg and then is like, let's do this surgery. Aren't you going to take an x-ray? Yeah, you told me this story. I know it's up. Go to a neurologist for your crushing migraines. They're not going to do an MRI of your head? No effing way. Neurologists live for that shit. Cardiologist? Yeah, sounds like you got a bad ticker. Yeah, no EKG. It's insane. In psychiatry, we don't do that. This is the state of the art, literally, in clinical medicine, in my field. You come into the doctor and you say, doctor, my mood is depressed. And they say, oh, you have major depressive disorder. We put other words around it, and suddenly it's an illness. There's no biological assessment, and then the treatment, shockingly, antidepressants. Anxiety, God, I'm so anxious. We heard about that before, and we heard how complicated that can be. You have generalized anxiety disorder. Again, 2 words on either side, and we're set. No biological assessments when we just heard how biological that was. And we give you anxiolytics, for those of you who are not fans of, I think this is from Latin, lysis is breaking something up, so it'll break up your anxiety. Inattention, oh, you must have attention deficit hyperactivity disorder. Tell me, oh, you have trouble paying attention, okay, great. Stimulants, we're going to give you speed, literally amphetamines. Literally, including methamphetamine. I can still prescribe that to this day in pill form if I wanted to, which I don't. Psychosis, well, we have a different name for that. We call that schizophrenia in most cases. No biological assessments, and shockingly again, antipsychotics. It says it in the name. Take the drug. This is the same methodology we used to diagnose Lincoln in 1840. Like, okay. So, can we look at the organ we are treating as mental health professionals? And the answer is yes. We have a variety of ways of doing that. So I want to talk a little bit about what our group in collaboration has done, learning from over 1,000 to 125,000 brain scans. But first, I'm going to introduce you to what neuroimaging modalities we have at our disposal. So you've probably heard or seen of structural MRI. This gives you a picture of the structure of the brain. They actually just today approved a 7 Tesla MRI magnet, which is very exciting if you like detailed pictures of static things. But unless you have a tumor or a stroke, this doesn't tell you fuck all about function. So all of the mental illnesses we have, like, they do not show up here. I mean, you may be catching a neurological thing, like a big, massive tumor making you act weird, but it won't catch depression. It certainly won't differentiate it from trauma at this level of fidelity. We developed functional magnetic resonance imaging, which takes structural MRI and overlays on it changes in oxygenated versus deoxygenated hemoglobin and the proton spins of the protons attached to those molecules, and can tell basically metabolic function. So we can look at blood flow as it changes over time in different areas of the brain, and then we can assess functional connectivity, which is a term that implies things are connected or unconnected. It's not a trick question. Connected. They're not connected in any physical way. Functional connectivity means the blood flow changes in that part of the brain the same time it changes in that part of the brain. It says nothing about actual physical connections of any neurons to any other neurons. It's correlation, and the studies are small because it's expensive. It takes like 4 hours. So fMRI has yet to lead to any useful clinical guidance, despite the billions of dollars we've spent on this. We need a better picture that's easier to get. And that's what my group is doing. So you're all going to join me in becoming amateur radiologists right now. That looks like a brain, right? It is. It's a picture of a brain taken with SPECT imaging, which I'll describe in more detail in a minute. Now, let's see how well you do in radiology residence. Can you tell the difference between that brain and this brain? Yes, right. This is not fucking rocket science. And they looked at me like an insane person when in my training I was like, why don't we just look at these things? They're clearly different. They're like, it's not out of the lab yet. Yeah, right. So it's different. This is not rocket science. Those patients came in, by the way, presenting with the same symptoms. Turns out one of them has major depressive disorder, and the other one has Alzheimer's, dementia, and was presenting with depression symptoms in older age. But you can see there's like, a mouse eating cheese in that brain. So SPECT stands for that's from PET scanning, single photon emission computed tomography. That's a typo, I'm sorry. This requires radiolabeled technetium-99, which is relatively easy to get as an isotope. It's nowhere near as difficult to make as the things we use for, say, positron emission tomography. And the radiolabeled nucleotide, emits gamma rays when it decays. And so we pair that radio-labeled nucleotide to a compound called, it's long, so I'm going to look at it, hexmethylpropylene amine oxime. The important word there for you guys is oxime, right? It sounds like oxygen, binds to hemoglobin. It's taken by the blood to the metabolically active areas of the brain. Except this scan takes minutes, not hours like fMRI. So those pictures are pictures not of the structure of the brain, but of the metabolic function of the brain. What metabolic demands are being placed on different areas of the brain that is bringing oxygenated radio-labeled tracer to that part of the brain so we can take a picture of it with a fancy, essentially X-ray but gamma ray camera. And these pictures are taken in real time as people are doing tasks in some cases. It's a very flexible technology, and it's quick and cheaper than any of those other modalities we saw. So why isn't everyone doing this? I mean, you all could see the difference there, right? Okay. Remember when I said I'm a Maverick? This is actually a picture of a Ford Maverick. Most research has been done with fMRI or PET scan, positron emission tomography, which again, that's literally detecting positrons, like the antiparticle of an electron is what they're discovering in those scans, and that takes fabulously expensive radio tracers and like 4 hours to get a PET scan. It's very expensive, it's long duration, and most importantly, from a research perspective, the sample sizes are by nature small due to expense, duration, and difficulty of getting people into the scanner. So we're talking about a sample size of 30, which really decreases the statistical power of what we're able to determine. So most of these results we've gotten, you hear about these on the news all the time. Scientists have shown that emotional pain is similar to physical pain. Scientists have shown that conservatives are more insane than Democrats, and none of those studies replicate, right? You have a small sample, and by chance, 5% of the time, you're gonna get a result. If you only publish positive results, almost half, on average, of what you read in the scientific literature, and certainly what is bastardized by the press, is bullshit. It's not true. And if you can't replicate it a second time, it's not science yet. It's a move towards a scientific theory, but it is not ready for prime time, which is why every drug you take, approved by the FDA, has been replicated in 2 separate randomized controlled trials, which, as of yesterday, includes 2 concurrent phase 3 trials for MDMA for PTSD. Most psychiatrists don't understand radiology, which is another limiting factor, much less advanced nuclear imaging scans like SPECT. I mean, we're a conservative bunch historically, not a lot of Mavericks. It's more like Corollas. So our sample size by this time, and this is further than the data I'm going to present, but is 125,000. And you can see here with my statistical example thing that your ability there to get more power has to do with the sample size, and you want to show a difference between the control group and the treatment mean. So, as I said, these are different. Same symptoms on the checklist of symptoms in the DSM. Both of these people came out as having depression. But antidepressants were not going to do fuck all for that person. They needed Aricept and neurostimulation, actually, in this case. And in the depressed case, major depressive disorder, well, in this case, this scan indicates that SSRIs are likely to be more effective. But what we wanted to show to our colleagues and be able to help them, because as I said, most psychiatrists are shitty radiologists, and if we can do these scans easily and improve the decision-making capability of people who have no ability to interpret these scans, then we're winning, because we're not going to get every psychiatrist to go back to radiology residency. So the gold standard in research is a randomized controlled trial. Here is the trial we designed. So using several cohorts, which I'll show you in a minute, the results from those individual cohorts, we had 12 blinded psychiatrists who were not privy to the clinical diagnosis. And they were each given out of our data set at this time of, in each individual study, a sampling of 300 SPECT scans to make presumptive diagnosis for them. They actually provided us with a rank order list of likely diagnoses between 3 and 5. We then fed that expert information and basically taught a neural network. We actually borrowed Watson for this, which was pretty cool that you can now rent out Watson time. And we're able to teach the computer how to do the same identifications the psychiatrists were doing, itself, and it actually, as you can see, was able to do it. We then gave novel SPECT scans that the computer hadn't had a diagnosis for before, and would run those through the neural network that was trained to recognize different disorders from each other. We compared that to a cohort where we had an initial presenting diagnosis to the research study. We then had the gold standard for diagnosis, which is called the SCID, the Structured Clinical Interview for DSM-4 at this point. It hasn't been updated for 5 yet. And that is the gold standard for diagnosis. Of course, it's still based on interview. It's imperfect, but it's the best we have. And then we took those patients and compared the rate of clinical versus SCID diagnosis, and were able to see if the computer algorithm, when applied to that, could improve the rate of concordance between clinical diagnosis and SCID diagnosis with the addition of the neuroimaging information. And lo and behold, we could. So our colleagues in the Amen Clinic, who are doing this more than anybody else, Daniel Amen's a real pioneer in the field and quite a maverick himself. Back in 2012, their sample was 55,000. And the relative risk, RR, of an incorrect diagnosis, relative risk is a measure of basically percentage of the time that you're going to get one thing or the other. So greater than 1 is riskier, less than 1 is less risky, and it ranges from 0 to whatever the fuck. So Amen's group with the statistical significance, and over there P, if you've heard of this in science, P of 0.05 is what we consider statistically significant, but lower than that is more believable. And Amen's group with that extremely large sample size and our methodology were able to reduce the risk of incorrect diagnosis by a relative risk of 0.56, which is essentially 56% less chance that your psychiatrist is going to fuck it up based on just talking to you. My group at the Nathan Klein Institute and the NYU School of Radiology were able to reduce the risk by even more. We had a more homogeneous sample because most of these were adolescents and children, borrowing from the public data set from the Healthy Brain Network, which is actually our rivals at the Child Mind Institute doing. And Michael Milhelm has done a mitzvah, and he's made all that data public. So we were able to use that along with their comprehensive neuropsych testing to test our neural networks diagnosis improvement and we were able to reduce the risk yet further, and it was still significant. You can see Argelian's group at Northwell Health, using a sample of patients with psychosis, approached significance at 0.08 but didn't get there, and their relative risk was 0.67, which wasn't as robust because they had less patients. Sarpal and Kane looking at a sample of patients with schizophrenia, and it's really Deepak Sarpal. John Kane's on there as the senior author because he's his boss. He didn't do fuck all for this study. And they, in their sample, 1,400 patients, didn't see it. Not significant, and really no reduction in relative risk when we applied our algorithm. And I don't know if that's because they had low quality data or because their schizophrenia population just wasn't as amenable to this as the perhaps due to the underlying heterotopic nature of schizophrenia for the algorithm to tell. The other populations were pan-diagnostic, so they weren't, the psychosis sample from Argelian was all psychosis, so mood, schizophrenia, etc., and all our samples included, anxiety disorders, some normal controls, and any other, psychiatric condition, depression, etc. So we've proved that we can reliably increase the validity of psychiatric diagnosis by taking SPECT neuroimaging and pairing it with a neural network, which can give a weighted score to a psychiatrist to compare with their clinical impressions and increase their ability to discern, based on their training in clinical interview, what is one kind of psychiatric diagnosis from another. So it's less Alzheimer's patients, less brain trauma patients, less depressed patients diagnosed as each other. And that's the work we've done.